Nice. So, hi everybody, and thanks for coming this afternoon to hear me talk about acne. So, as we know, acne is a very distressing, a very common condition. It can scar, but there's many treatments there that can prevent the distress. The distress is unnecessary, as is the scarring. So, that's why I'm here today to hopefully empower you with the information so as to um, help you take control of your acne, or maybe you have a loved one who has acne and it might help you help them take control of their acne. As well as that, it can be quite hard for patients with acne when they're on the internet and they're quite distressed, they're vulnerable. And there is a lot of very convincing misinformation out there about acne. So I'm going to also address that today during the talk. So as I said, acne is very common. They say that it tends to present typically in early adolescence. And they say that about 80% of people between the ages of 11 and 30 are affected by acne. So it's hugely prevalent. And in some cases, acne does persist until adulthood. It's more commonly an issue for women than men. They say 5% of women and 1% of men have acne over the age of 25. So I suppose what causes acne? And I think we need to just have a little look at this image, try and understand it, because understanding this image will help us understand the treatment modalities that are out there. So this is essentially, there's a fancy name and then there's I suppose, the more simpler name. This is essentially a pore on your face or on your trunk. It's called the pilosebaceous unit. That's the fancy medical term. You can see here, here's your hair follicle, the hair coming out of it. These are the sweat glands that feed into that duct. So what happens is that in puberty, there's an increased androgen hormone. So there's increased sex hormones being produced and circulating in the adolescent's body. And they stimulate these sweat glands and leading to a production of sweat into this pore. And what happens is that there's a bacteria called Cutibacterium acnes that really likes the sweaty environment of the pores on your skin. So that bacteria colonizes the pore and it starts to multiply, resulting in inflammation, leading to those red pimples, those red pustules, those sore nodules that we all know and recognize. In addition to that, the cells that line that pore, that hair follicle, follicular duct there, they also multiply and they block that duct. And that results in blackheads and whiteheads. Okay. So these are just pictures of those pimples, those papules is the medical term we use, those pimples and those pustules. They're quite inflammatory looking, they're red. And these are the pictures of the blackheads and whiteheads. So they're not as inflammatory looking. And we have a different treatment approach for the pimples and pustules versus the blackheads and whiteheads. But generally speaking, people have a combination of both. So I've spoke about what causes acne, but there's also factors that can modify or potentially worsen acne. So typically in the adolescent that experiences acne, it's not that there is more sex hormone in their body versus their friend who doesn't have acne. It's just that their sweat glands are more sensitive to the hormones than their friend that doesn't have the acne. But hormonal factors do play a part in other ways. So 70% of females will notice an aggravation of their acne just before or in the first few days of their period. And that might help you understand why the oral contraceptive pill, which I will talk about later on, can help the management of acne for these patients. Also, some women can experience polycystic ovarian syndrome, and this would explain for some people why their acne may just present in adulthood. I'm going to talk about diet later on. So cosmetics, oil-based cosmetics, they can clog your pores. Hair pomades, those kind of greasy gels that typically young guys might use in their hair, especially if they've got a fringe, they're going to block the pores and make them more susceptible to acne. Drugs, so anabolic steroids, which we don't want to see any of our young male adults or use. They can be taken by them, especially if they're big gym goers. Oral steroids are another contributing factor. Whey-based protein supplements, the evidence has shown that they can worsen acne. They're high glycemic index food supplements, and it's because we think it's because of that high GI characteristic that leads to increased risk of acne. Friction from protective sports equipment, helmets, boxing headguards, they can often result in occlusion of those pores, resulting in acne spots. Excessive sweat from working in a warm environment, and family history is also most definitely a factor. It's important to acknowledge the psychological burden that is associated with acne. It's been associated with higher rates of low self-esteem, embarrassment, frustration, social anxiety, and depression. This is all unnecessary. We have got good treatments out there. This does not need to happen. So what would I recommend to help somebody if they're trying to manage the first signs of acne? So we recommend that someone washes their face twice daily. If their face is oily, use a foaming facial wash because that is quite good at removing excess oil that can block those pores. Wash makeup brushes regularly. Wash hair regularly, especially if oily. Try to keep hair out of your face, especially your fringe, and avoid those greasy hair pomades. Choose creams, sun creams, cosmetics that don't block your pores. And oftentimes these products say non-comedogenic on them, so that might help you. And then it can be so tempting, everyone probably does it, but do not burst those spots because that increases the risk of scarring. So over-the-counter products. So I suppose I have a couple of points that I just want to stress here. Do not spend loads of money on over-the-counter products because you're wasting your money, okay? Give the over-the-counter products 2 to 3 months. If they haven't worked at that point, then they're not going to work, and you need to make an appointment with your GP. You need to get prescribed medication for your acne. So if you're if you're with your local pharmacist and you're wondering, well, what treatments should I go for? I would say that there's a range of price. There certainly is a price range. You don't need to go expensive. And the ingredients to look out for in these potential over-the-counter products include salicylic acid, nicotinamide, and benzoyl peroxide, and azelaic acid. These products can be found in the cleansers, in the moisturizers, in the facial washes, and that's what I would suggest you look for in your local pharmacy, and talk to your local pharmacist about this because they are well used to advising patients and sending them in the right direction. So when do you see your GP? If you are distressed about your acne, make an appointment to see your GP. If the over-the-counter products have not worked within 2 to 3 months, go to see your GP. If your acne is scarring, most definitely make an appointment to see your GP. And if you have like a moderate, severity acne, most definitely you need to just not bother with those over-the-counter products. You need to just go and see your GP. So I'm just going to show you some pictures of patients with acne and just tell you, well, if that person arrived to me in my GP consultation room, what would I do? So this patient here, as you can see, I would grade this as mild to moderate comedonal acne. So it's mainly blackheads and whiteheads. It's not particularly red looking. So first of all, when I'm managing a patient with a skin condition, I always like to empower them with information about that condition. So I would direct my patients towards the Irish Skin Foundation website. There's an excellent information leaflet on acne, and it'll definitely, once you feel empowered with knowledge, it makes you feel more in control of your condition. So in that patient who has that mild to moderate comedonal acne, I would go with a topical retinoid. So it's not an antibiotic, it's actually a cream version of oral isotretinoin or Roaccutane, which you may have heard about. And what it does is that it dries out the skin, it reduces sweat production from those sweat glands. It also reduces the proliferation of the cells lining that pore that I was telling you about earlier on. And they're very good at treating blackheads and whiteheads specifically, but they can also be very good at treating pustules, those pimples. And topical retinoids are also very good at preventing the recurrence of acne. But it's important to manage patient expectations. So oftentimes a patient might have been prescribed a topical retinoid, stopped using it after 2 weeks because there was no improvement. So it's important to highlight the fact that a complete course of a topical retinoid, you need to give it 2 to 3 months. It might flare up your skin in the first couple of weeks, but that's to be expected. Just keep going with it. You also have to start gentle with the topical retinoid. If you put on too much too soon, or if you put it on every night when you first get it, it will excessively dry out your skin. It'll lead to an irritant dermatitis. You won't like the medication and you're going to stop using it. So what we'd say is to use a pea-sized amount, that's all, applied to where you have acne and to where you normally get acne. Put it on every third night for 2 weeks, every second night for 2 weeks, and then every night thereafter. We say to put it on at nighttime because it renders your skin more sensitive to the sun. Also, we would say that you should wear a sun cream while using it. So when you're putting on your sun cream in the morning, you need to choose what we call a non-comedogenic sun cream. So sun cream that isn't going to block your pores. And again, your local pharmacist will be able to put you in the right direction in this regard. Okay. When you're using the topical retinoid, you need to be careful with the moisturizer that you're using and the cleanser that you're using. So you want to use a gentle cleanser, a gentle moisturizer. You don't want to be using a moisturizer that contains salicylic acid or nicotinamide because they will also dry out your skin and they might prevent you from being able to tolerate the topical retinoid. So go gentle with your moisturizer, gentle with your cleansers. And also avoid topical retinoids if you're planning to become pregnant or if you are pregnant. They're technically teratogenic and can. Okay, so if somebody came into me with acne like this, I would say this is most definitely at least moderate severity acne. It's quite red, it's inflamed. You can see the papules and the pustules there. So I would manage this person a bit differently to the first patient I discussed. So this person needs an oral antibiotic. They need a tetracycline antibiotic for 3 months. It's a 3-month course, not a 1-week course. And we give the person an antibiotic not because acne is a skin infection, but because these tetracyclines act as anti-inflammatories. So to help take away that redness, to help get rid of those papules and pustules. It does also reduce the number of bacteria, that bacteria that I told you was implicated in causing the pustules and the papules. We never prescribe an oral antibiotic or an antibiotic tablet in isolation when it comes to acne because we're worried about antibiotic resistance is one thing, and we can maximize the efficacy of the treatment by adding in a topical retinoid in addition to that tetracycline tablet. So I would give the person a topical retinoid, as I already described, in addition to the tetracycline antibiotic. If the patient was female, I would tell them they can't get pregnant while taking this medication. Tetracycline antibiotics, they actually can result in permanently discolored teeth. So it's definitely not something you want to happen. Thankfully, I've only ever seen it happen once. But yeah, women can't get pregnant while taking this medication. Tetracycline antibiotics, just like the topical retinoid, it can make you more sensitive to the sun. So again, you need to be wearing that sun cream that doesn't block your pores. A full course of treatment is 3 months. I would want this patient's skin to be fully clear. I would tell them to come back to me at the 3-month mark if their skin isn't fully clear. I would also want to see them again if they're fine at the 3-month mark, but then maybe a month after that, their skin starts to quickly flare again. I'd need to see them at that point. So just another, a bit more on moderate inflammatory acne in a female patient. So as I already said, 70% of women can have flares of their acne around their periods. So the oral contraceptive pill is an option. If there's no contraindications to them being prescribed the oral contraceptive pill. So I would prescribe Dinet would be my first line. It contains an anti-androgen, so it counteracts that the androgen hormone that can or stimulate the sweat glands, and it works quite effectively. It might take 3 to 6 months before being fully effective, but it is a very effective treatment of hormonal type acne. With this patient, I would also recommend a topical retinoid with that. And if they were really distressed about their acne, you could also put them on an oral antibiotic with that as well. So, as I said, if that person, if they got recurrence of their acne, so this is actually just a case I want to discuss. So, patient, they were fully clear 3 months after their 3-month course, and then 1 month after stopping their treatment, they experienced a recurrence and they came back to me. What would I do then? So I'd put them on another antibiotic, but I could put them on it twice daily, and continue a topical retinoid with that. But I would also refer them to my local dermatologist for consideration for oral isotretinoin. So you've probably heard a bit about oral isotretinoin, and when should it be considered as a treatment? So these would be the scenarios. So if someone has severe acne, if they're not responding to the treatment I mentioned, if their acne quickly relapsed after completing a course of the treatment that I prescribed, if their acne was scarring, and if they were really distressed about their acne, I think it certainly merits consideration at that point. So how does it work? So it's actually the only cure for acne. It cures acne in almost all situations. Some people might need a second course of it, but it's huge. It is really effective. I've seen lots of patients being treated successfully with oral isotretinoin. So it reduces sweat production by 90% from those sweat glands I was talking about. It can reduce blackheads and whiteheads by 90% within 3 months. It doesn't directly affect that bacteria that I was talking about, but it alters the environment in which the bacteria lives to such an extent that the bacteria doesn't want to live there. So through reduction of the sweat. And through that effect, it actually reduces the number of bacteria living in those skin pores. It's an anti-inflammatory effect as well. The course length tends to be typically up to 6 months, and most patients achieve 100% improvement. So side effects, so there's common side effects and there's rare side effects. So the common side effects, dry lips, dry skin, dry eyes. So we always spend time in the dermatology clinic advising patients on the need to apply a good, gentle moisturizer and a good, gentle facial wash. So like I said earlier, not a facial wash containing salicylic acid or nicotinamide or benzoyl peroxide. They need to go gentle with their cleanser, gentle with their moisturizer so that they tolerate the oral isotretinoin. They need to be using their lip balm. And Roaccutane does render your skin more sensitive to the sun. So you need to be using a sun cream that won't block your pores. It can cause joint pains, muscle pains. So if someone's very athletic, this might be an issue for them. It's not an issue for most people. Sometimes acne can flare in initiation of the Roaccutane, but the dermatology team will be able to deal with that. There is a need for a blood test 1 month before you start on Roaccutane and 1 month after, because there is a risk of your cholesterol levels going up or your liver bloods going off. But I've actually seen an awful lot of patients go on Roaccutane, and I've actually never seen this happen, so it's quite rare. We tell patients to avoid waxing, laser peels, and surgical procedures if possible for 6 months following a Roaccutane course, because it can affect the healing. Now I'm going to talk about teratogenicity and mood changes in the next slides. So pregnancy is not an option for a female patient on Roaccutane. So there's no issue if you've got a male patient on Roaccutane. We don't have to worry about them. But female patients, pregnancy is not an option. That's why it's advised that a woman goes on 2 forms of contraception, one of which can be barrier. They need to have 2 negative pregnancy tests before they start the treatment, and then they need to have monthly negative pregnancy tests thereafter to allow for ongoing prescription of the medication, and they are not allowed to conceive for 1 month after completing the medication because it takes that time for the Roaccutane to get out of their system. And it's once the person finds out they have a positive pregnancy test, it's actually too late. Stopping the medication at that point won't prevent the numerous abnormalities or possible miscarriage that can happen. So we really stress that to our patients. Mood, you'd probably see a lot about Roaccutane and mood in the internet. Large database studies have shown no increase in incidence of suicidal ideation or depression amongst patients on Roaccutane. The FDA has reported temporal associations between the use of the drug and depression with positive D-challenges and re-challenges. So I suppose, what does that mean? And I have seen this happen in the clinic. So persons on Roaccutane, they might be fine in the lower doses. As they go up in dose, their mood might dip. You take them off the Roaccutane, their mood improves again. It's important to stress to patients that Roaccutane is a very short half-life, which means that it's out of your system within a few days. When we're counselling the patient about Roaccutane, we want them to have a family member with them, because sometimes the person themselves might notice a dip in their mood, but their family member will. So we would say to them, listen, a dip in mood can occur. If it does, you need to tell us straight away and tell a family member. But a lot of the time, what I see with patients is that their mood's actually improving because they're delighted with how effective the treatment is. So acne and skin of colour, it can be a bit more challenging to treat because while we would use the same treatments to treat active acne, they're a bit more prone to what we call post-inflammatory hyperpigmentation. Okay, which is a bit of a mouthful, but it means that when the active spot has resolved, it's left some pigment on the skin, some dark brown pigment on the skin, that for some people can be permanent. Now, it may last up to 18 months, and as I said, for some people it can be permanent. So we really need to be aggressive in our management of acne in skin of colour so that this doesn't happen in the first place. If it does happen, azelaic acid twice daily can be prescribed to help reduce this post-inflammatory hyperpigmentation, which hopefully will also improve with time. Scarring, there's different types of scarring. This is unnecessary. And we really don't like to see this happening because this could have all been prevented. So there's different types of scarring. There's scarring that causes dips in the skin. There's not too much that I as a GP can do about that. If someone was distressed about that, I would say, listen, you need to link in with a cosmetic dermatologist to see what can be done there. Keloid scarring is where you get excessive scar tissue formation due to acne spots. They can be tender, they can be itchy. So I can inject them with steroids, which won't get rid of them, but will make them less bothersome for the patient and will flatten them somewhat. But again, it's cosmetic dermatologists that they also need to be thinking about there. So you're probably wondering as well, facials, are they worth doing? What is the story with them? They're expensive. So we call them physical therapies. So I think it's important to go to the guidelines here. So, because if you go on the internet, it's hard even for a doctor trying to figure out, well, what's our stance here. So you'll have some papers that'll say they're beneficial. You'll have other papers that'll say they're not beneficial. But if you go to the British Association of Dermatology or the American Association of Dermatologists, they will have looked at all the research and they'll have come up with a conclusion. So I just took a quote from the American Academy of Dermatology. And what they said about those physical therapies is that there is limited evidence to recommend the use and benefit of physical modalities for the routine treatment of acne, including pulsed dye laser, glycolic acid peels, and salicylic acid peels. And according to the NICE guidelines, there's only a role for photodynamic therapy if no improvement with topical treatments, antibiotics, or isotretinoin. And then I suppose what do we say about herbal treatments or alternative therapies? So again, I think it's important to go to the guidelines. This is a quote from the American Association of Dermatology guidelines. Herbal and alternative therapies have been used to treat acne. Although most of these products appear to be well tolerated, limited data exists regarding the safety and efficacy of these agents to recommend their use in acne. So we don't recommend their routine use. A lot of my patients ask me about diet. So diet, what I say to patients is that diet is not the main cause of your acne. Changing your diet is probably not going to make a difference. And what the guidelines say is aim for a healthy, balanced diet. So safefood.net, it's an Irish website, and there's loads of really helpful information there to tell you, well, what is a healthy, balanced diet. So there is, I suppose, the strongest evidence that out there in relation to diet does suggest that a low glycemic index diet is associated with a reduction in acne lesions. Now, we still don't routinely recommend it to our patients. We say healthy, balanced diet, but this is where the main evidence would lie. So that's just a picture of what typical low GI foods look like, whereas high GI, they're all the nice, tasty, very processed foods there. So trying to avoid them might help. I already mentioned about whey-based products. So as I mentioned earlier, I think it can be really hard for patients that are distressed with a skin condition and they are seeking out information on the internet about their condition, because there's an awful lot of very convincing misinformation out there. So I don't know, hands up anyone who's encountered something like this on the internet that connects Candida with acne? Okay, nobody here. Oh, yeah, we've a couple. Or how we cured cystic acne with one simple diet change. And or you may have read something like this. So the doctors we saw all eventually recommended the powerful acne medication Accutane. So Accutane is the US name for Roaccutane or oral Isotretinoin that I already mentioned. Since the acne wasn't responding to any other treatments, we had friends who had taken Accutane, so we knew about its reputation for bad side effects and wanted to avoid using it if possible. And you can imagine that this would steer your attitude towards Roaccutane, but there is no evidence base to what they've said. So there was a really interesting paper published by Cathal O'Connor and Dr. Michelle Murphy last year. Cathal O'Connor is a dermatology SPR, and they looked into medical misinformation in relation to acne. So they found, what they explored was the PubMed, Google, TikTok, Twitter, Facebook, and Instagram. So I'm going to go through what their findings were. So they found that the main themes of acne misinformation included diet, other proposed causes of acne, unconventional acne cures, and a lot of misinformation was just in relation to demonstrating a distrust of conventional acne treatments. So just to go on about misinformation relating to diet and acne. So dairy products were most often cited, and although previous studies have shown that there may be a very modestly increased risk of acne with higher milk intake, there is no evidence to suggest that it causes acne. And then of course we have to think of, if you remove dairy from your diet, what will that do? It could well leave you calcium and vitamin D deficient, which is further implications, like it might put you which would put you at increased risk of osteoporosis, bony fractures in later life. Other alleged dietary causes included chocolate and greasy or high-fat foods. We know that there's no evidence there to support that. And just to highlight again that where the main evidence lies in relation to diet is that a high glycemic index diet can worsen acne. But even though the main research base is actually behind a low glycemic index diet, that this can help, there was actually very little promotion of this on online forums. So, misinformation in relation to causes, so proposed or alleged causes of acne. So, acne was occasionally incorrectly attributed to poor hygiene. So, if you're already distressed with your acne, someone suggesting that your poor hygiene is exacerbating this it's just going to compound that distress further. And it's usually the people promoting this as a potential cause, they're usually companies selling facial washes or antiseptic products. Um, Systemic infections were also claimed to cause an acne, particularly streptococcus and yeast overgrowth, with candida cleanses championed by wellness practitioners. So again, no evidence based here. More extreme blogs declared that the hidden cause of acne was fluoridated water, with no plausible scientific basis provided. So now, misinformation in relation to proposed or alleged cures of acne. So veganism was frequently mentioned. And although veganism has many tangible benefits, such as reduced risk of cardiovascular disease, the decreased environmental impact, and also the ethical considerations that go along with it, there is no supportive evidence for veganism in reducing acne severity. But despite this, several veganism support groups claim that veganism can rapidly clear your acne. So then misinformation for cures of acne. So branded creams, often branded as miracle cures, achieving clear skin within weeks when other conventional treatments have failed. Don't trust something that's being presented like that. Cures that are being marketed as being natural or herbal, be highly suspicious of it. Other wonder treatments for pimples included toothpaste, lemon juice, and garlic. Nutritional deficiencies were frequently mentioned as a cause of acne. Again, there's no evidence base for this, with expensive supplements being recommended to achieve clear skin. And examples of these recommended supplements included zinc, magnesium, and probiotics. This one's a tough one now to actually pronounce, but we'll call it DIM. So with its abbreviation. So it's a compound found in cruciferous vegetables, and it was touted as a hormone balancer, which blocks androgen receptors and promotes production of good estrogen. All sounds plausible, but there is no clinical studies assessing the use of this in acne. And a medical medium also claimed to cure your acne if you bought his book for $17. So on the internet, there was criticism of conventional treatments. Antibiotics were referred to as pollutants with health-ruining effects on your skin and the gut microbiome. Isotretinoin was vilified as toxic with profound and irreversible adverse effects. This is all false. The previously reported association of isotretinoin with inflammatory bowel disease was also reported online. But I want to point out that more recent, higher quality reviews have confirmed that there is no increased risk of inflammatory bowel disease with isotretinoin. Blogs also exaggerated the risk of organ injury with isotretinoin, saying that drugs often cause liver or kidney failure, whereas the truth is that laboratory abnormalities are extremely rare in patients on isotretinoin. Isotretinoin was falsely linked with infertility, erectile dysfunction, and sexual dysfunction. Again, all false. People often ask about acne in the sun. So we would say our message is avoid suntan. Suntan is sun damage. Unless it's fake, you're wearing fake tan, we're all for fake tan, but just not suntan, and avoid sunburn. So a sunburn can redden your skin, suntan can darken the skin, it can make acne less visible, it can make your skin feel better, more dry, but these perceived benefits they're temporary, and you have to think of the increased UV exposure that comes with suntan, that comes with sunburn, that subsequently increases your risk of skin aging and also skin cancer. And also, if you're on, just to stress again, when you're on prescribed treatment for acne, they do tend to make you more sensitive to the sun. So definitely even more of a reason not to go for the suntan. Okay, so I want to discuss just other types of acne that you may want to learn more about. Neonatal acne. 20% of babies have papules, pustules, but there's no blackheads. So it can look like, yeah, well, to be honest, it's rare that you would encounter a baby with a rash like this. But I would see babies quite commonly with neonatal acne. It's different to the acne that I've discussed already. It's associated with a yeast called Malassezia furfur. So the treatment tends to be centered around treating that yeast and the inflammation that accompanies it. So it tends to not bother the baby, it bothers the parents much more than the baby, and it resolves within a few months. Infantile acne, I rarely encounter it in general practice. It can present from 3 to 6 months. It involves maternal hormones and the awakening of the sweat glands. There can be blackheads and whiteheads and inflamed pimples. It usually resolves by 1 to 2 years, and you can give a topical retinoid for it. But again, I've never had to treat this in general practice. Rashes that can be confused with acne, so rosacea that Professor Tobin was talking about earlier, or a periorificial dermatitis or a perioral dermatitis. I encounter this quite commonly in general practice. So it's where someone gets these red pimples, but crucially, there's no blackheads and whiteheads. It tends to be around their mouth, around their nose, and potentially around their eyes. So it may have just come out of the blue maybe 6 or 7 months ago. It might be preceded by steroid cream usage, and there might be ongoing steroid cream usage because it will relieve the rash, but never get rid of it fully. They stop the cream and then it worsens and it rebounds, and they think the cream is making it better. But actually, it's the contrary. The cream is propagating the problem. So what we do is we stop the cream, and if someone came to me with a rash like this, I'd put them on an oral tetracycline for about a month, and that would sort them out, and they should never have a problem again, hopefully. Yeah, so that's the end of my talk. So hopefully I've empowered you a bit in helping to take control of your acne or the acne of a relative.